Good morning, everyone. Welcome to ILFA's second Patient Information Day of 2025. And as folks are joining us, we'll just go over a few brief points. Your cameras and your microphones are going to be switched off. This is a webinar, so just sit back, have a cup of tea, and enjoy our presenters today. You can ask questions using the Q&A button at the bottom of your screen, and I would invite you to ask questions. It's really good when we get those in, because it helps to foster communication and engagement with the presenter. So it would be great if you submit questions. Make sure that you do that through the Q&A. If you lose your connection, just go back to the calendar invite that had the link to it. Click back on that and Kelly will let you back in. And then just as a note, today's event is being recorded. We will post that out on our YouTube channel. So do me a favor and go out after this event and like and subscribe to our channel. And just to say, in terms of our agenda, we're in the first part here. I'm Maureen O'Donnell, and I am going to be your moderator for the presentation today. And we've got some really interesting speakers. We have Paula Ryan, who is going to be speaking to us about living well with pulmonary fibrosis. Then we've got Dr. Aoife Carolan, Dr. Anja Schwekert, providing research information. We have Professor Adam Byrne coming in with, he's reprising his role in a previous webinar where he talked to us about understanding the role of lung inflammation. It's one of our most viewed webinars, so that's going to be really interesting today. And then, as always, we wrap things up with our patient story. And today we have a really exciting guest speaker, David Crosby, who's just finished up the Chicago Marathon. So that's amazing. In between that, we'll have a little comfort break, and then I'll do a bit of an update on the work that we've had this year in ILFA, and then a little bit about our plans for next year. So with that, I think we can go ahead and bring our first speaker up. We have Paula Ryan, and Paula has worked in the, I'm going to stop sharing my screen so that Paula, you can come in and share your screen. And while Paula unmutes herself and brings her video up and her screens up. So Paula's worked in the respiratory service in University Hospital Limerick since 2010. She previously worked as a staff nurse in high dependency unit, intensive care unit for 6 years. And that's where she got her interest in respiratory medicine. She's an advanced nurse practitioner in respiratory with patients that have symptoms that are suggestive of asthma, COPD, and ILD. Now, this weekend, she's going to be in Cavan with her daughter and her husband, and they are going to be doing something completely different. Her daughter really loves ponies, and so they're going to be at a horse show in Cavan. So prior to that, she's come to speak to us about You're Not Alone, Living Well with Pulmonary Fibrosis. Welcome, Paula.
Thank you so much, Maureen. I'm just going to share my...
I was going to say we can see your slides, but we can see them kind of as the notes.
1 second, I'm going to fix that now. I don't know why it's not letting me fix it. 1 second.
Okay.
2 seconds, sorry.
No problem.
My screen. Not letting me do it another way. I'm sorry. It's a little bit different to how it was. I'll try one more thing.
There was something that you did before. Was it something about slideshow up at the top or display settings maybe that you're clicking on?
It's not letting me do what I did before for some reason.
Unshare and try again.
Yeah, I'm going to try it again. Now, is that it? Perfect.
Perfect. Well done.
Brilliant. So, 1 second, it's not in front of me now. It's actually on my left now rather than in front of me. I'll move this over a little bit. So my name is Paula. I'm an advanced nurse practitioner in University Hospital Limerick. So I work with a group of respiratory consultants and respiratory nurses running pulmonary fibrosis clinics. So where I would come in my role, seeing patients is when they get presented first. And I hope I can get across what our role is and how we can support patients with pulmonary fibrosis, idiopathic or progressive pulmonary fibrosis. So I want to talk about understanding pulmonary fibrosis, but I know there's a consultant speaking later, so I'm not going to go into in depth into that. I want to talk about the signs and symptoms of the disease, what options there from a medicine's point of view, pharmaceutical, for patients help stop progression or slow progression of their disease. I want to talk about non-pharmacological supports for patients like pulmonary rehab, exercise, mental health supports, and then ILFA and the supports that ILFA has for us as healthcare workers, but also for our patients and all the patient information leaflets that we get, which is fantastic support for us. But idiopathic pulmonary fibrosis, or PPF, progressive pulmonary fibrosis, what does it mean? Idiopathic means that it's an unknown cause. Pulmonary, that it's involved in your lungs. So this is a disease that happens in the lungs. And fibrosis, what that means is that we've increased scar tissue in our lungs. So it is a serious lung disease that causes your lungs to become thick and stiff and more difficult to breathe. And the disease gets continually worse over time without supports. Progressive pulmonary fibrosis, and as I know there's a consultant speaking later, I'm not going to go in again to depths of this, but progressive pulmonary fibrosis in the last few years, so patients that have had other fibrosis caused maybe because of rheumatology problems or other concerns or other issues or inhalants, have got progressive pulmonary fibrosis, and a lot of those patients are presenting to us in the last few years, and again we're supporting those patients with medications and non-pharmacological supports also. But just understanding pulmonary fibrosis, looking at the normal lung and alveoli. So this is looking into our actual lung. And you can see here on the left-hand side with the normal lung, and in comparison to the right side where you have this irregular abnormal air spaces. If you kind of look at it and think it's not as round, it's not as normal, it looks thicker. If you can see here the large areas of scarring and fibrosis, it just looks thicker than the other side. A lot of patients presenting to us might have had shortness of breath for a few years or other lung problems for a few years, and they just sometimes feel miserable coming to us, and miserable because of the work and effort that they've had to maybe get to an appointment. And I believe we're not too unlike any other centre in Ireland, where we're a big busy hospital and it can be a challenge to get a car parked, walk down to a clinic appointment. And then when you're coming in for an appointment where you might be receiving some bad news and you're feeling it, you're feeling breathless, you've got a cough, you might be debilitated from it. So all these early signs and symptoms have been there, maybe preceding a diagnosis of sometimes up to 2 years. Now I think for some patients, thankfully, we're a lot better at picking up the disease. And maybe with the introduction, I think, of ILFA and GPs being educated on picking up the disease sooner, I think sometimes we're able to pick patients up a lot quicker than that precede diagnosis by up to 2 years. And hopefully, I think that because I'm in the area since 2010, I have seen a massive difference in the last 15 years where patients are picked up sooner. So I want to get out to patients today and people that may be watching, because I know some of my patients said they may log in, is that you're not alone. Please ask for help and ask for more help. Don't be afraid to come into an outpatient appointment if you get bad news, to ask for something to be explained again, ask to come back for another appointment, maybe for information to be given again, because sometimes I think when we meet a patient and outpatients, they meet a doctor, they're meeting a radiologist, they're meeting so many different people, getting bloods, x-rays, scans done, the nurse maybe at the last part of the appointment, and they're getting all this information. And I've just noticed over the years, patients go away and they've remembered half of what's been said. So I think it's very important for patients to be empowered to ask the nurse or the respiratory nurse that they meet, or anyone else that they meet in the respiratory service, please come and ask us, what does something mean? Like, I have a picture here of clubbing. I know some patients have noticed their nails change. There might be even hiding them. Some females might be embarrassed about the change of the shape of their nails. Ask, what does it mean? Why do I get this? Ask about their fatigue and their symptoms, because some patients know that the cough is maybe part of their disease, but they don't know why they're so tired. And I think we know all this information, but sometimes we need to get that information out to patients so that they understand, or when they're breathless, how we can support them with their breathlessness so that they're not feeling as breathless, and that they have little tricks of the trade to kind of help and support the breathlessness, that I will talk about again in a little while. And again, this slide is talking about really when a patient comes in, or a person and family member especially as well comes in, we speak a lot of medical jargon and patients sometimes don't understand. And I've just come from a clinic where a patient who I know is a family member of someone I know, and they asked me to repeat what the doctor had told them in the appointment because they didn't pick up all of what had been said in the appointment. So that is common, and that happens a lot. So I know that happens with patients that I see also. So usually when a patient or a person comes into the clinic, we do a physical examination. We're listening to their lungs, we're looking at their ankles, we're looking at the person as a whole, and we're talking to them about their symptoms. Is their cough dry? Is it productive? Have they finger clubbing? Have they shortness of breath? Or is that shortness of breath more so when they're moving, when they're walking? And then what I mentioned with the awareness with GPs and ILFA is that fine crackles and lung auscultation. What that means is listening to a lungs and hearing that Velcro sound on both sides of the lungs when a doctor or a nurse listens to the lungs. Getting pulmonary function tests, so a breathing test. And we want to see what type of disease you have. So is it restrictive or obstructive? But that's what that means. We want to know and get a number for where you are with that disease, how well your lungs are working, and looking at your breathing patterns. We also want to look at your oxygen levels, but not just when you're sitting down, when you're moving. So when you get up to walk, are your oxygen levels dropping? And that's, again, something that we would look at nearly at every single appointment that you come into. We look at bloods, and when patients are on medications, we look at certain bloods to make sure that they're tolerating the medications properly. And then we're in the process of diagnosing a patient, we're looking at selective different other tests like ANAs, and I won't even go into all of those bloods, but there's a lot of bloods that will be done at the start to try and see what type of fibrosis you are. We look at chest x-rays, and we look at CT scans, high resolution CT scans. It's a type of x-ray again that looks at images in slices, and that can be put together to provide a detailed picture of the lungs. And then in an ideal situation, when you have all that information together, that we go to a multidisciplinary team meeting and we talk with the experts, the respiratory consultants, the consultant radiologists, and the rest of the respiratory team, where we can look and see what type of lung disease you have, so we can give you the proper support and management with your lung disease. And I find, as a nurse in my clinic, a lot of what we're doing is asking and responding to patients' questions. Like, this is a regular occurrence for me, where patients come in and say, what did the doctor say to me? I can't believe this is so bad. Can you please give me more information? And I'm not ready to die yet. Patients have said to me, this can't be true. And like we all do, we all look up information on Google. So looking at Dr. Google and seeing 2 to 5 years, and then asking, I've had these symptoms for 2 years. Does that mean I'm going to die soon? There's no hope. I'm so relieved that it's not cancer. I've heard that so many times. But looking at all of those questions are something we can respond to on an individual basis and be very empathetic and acknowledge patients' concerns, worries about their disease and about their diagnosis, and support people and their family members when they come into a clinic. How can you support your patients in understanding their diagnosis? I think repeat information with empathy and compassion, but repeating, I feel is so important, because you could be on appointment 3 or 4 with a patient when they're just understanding what you said on the first appointment, and that's very normal and that's okay. So don't be embarrassed or challenged or find it difficult that you have to go back and ask the same questions. And it's okay to sit with your family when you go home and write down questions and come into a clinic and ask again, can you explain to me what this disease means? What do we do next? Can you explain to me medication again? I think it's very important for patients to feel empowered to ask those questions. Plan what to say ahead of time. Be mindful of individual coping strategies. We're all very individual and unique, so we do have different coping strategies. So each person requires a little bit of something different, and allow time for discussion. Support. I like when a family member or caregiver comes into an appointment with a patient, because when you're well, it's great to get to know someone, and when you're unwell, so that we can link and provide support for people when they're at home. And it's important for us to listen to how a patient is feeling and to try and build a relationship with our patients. Because learning the diagnosis enables patients to begin to cope and make plans for their future at home. A question, especially with the idiopathic pulmonary fibrosis rather than the progressive pulmonary fibrosis, is patients would ask, why did I get this? So there is some possible risk factors. A lot of patients may not have done any of these things. These are just possibilities. Again, it's an unknown cause, but there are certain risk factors like smoking, environmental exposures. We would have some people here in Limerick that work in the cement factory that might have fibrosis, or a big farming community here in Limerick as well, and we would have a demographic in farming also. So gastro reflux, silent reflux, we'd ask patients about, or any burning in their chest or anything. So sometimes it can be related to that, chronic viral infections or genetic factors. So these all can be reasons why, but we're unsure. They're links more so. Are there any medications that can help me? I remember, I think it was back in 2014 or 15 when I heard about the first medication that was coming. I think it was 2013, even 14, with the first medication for pulmonary fibrosis. And I remember our first few patients for antifibrotic medication. So there are medications, and hopefully in time to come, there will be even more medications. So with the medications, there's 2 medications of choice at the moment. And as in my current role is trying to support patients so that they tolerate the medication. So we may meet patients regularly, give them coping strategies and to try and tolerate the medication. Some patients don't have any problems tolerating medication, but others may have maybe GI upset or upset tummy, diarrhea, nausea, vomiting, or they may have their liver function tests might be deranged. And we've talked about maybe not drinking alcohol, not taking paracetamol if their liver function tests are deranged. So there's different, everyone's unique and everyone's an individual that we see. So we talk about all those things with our patients. Pulmonary rehab is so important. Moving for patients is so important, and especially we try and send a lot of our patients to Mater for a lung transplant assessment. And one of the things that Mater always requires is that patients are involved or have taken part in a pulmonary rehab program. And what that means is you go twice a week for a certain period of time, and with a physiotherapist and a nurse, and you're going through exercises. And even if you're not going for lung transplantation, and if you're not interested in any of that, it's just so important to try and stay moving and stay moving safely. I find sometimes patients are nervous about exercising if their oxygen levels are dropping when they're walking, and pulmonary rehab can give you back that confidence to exercise and move, and people really enjoy it. It's actually fun, and it's very rare that someone comes out of it and says that I don't want to do that again. So we're fortunate in the Limerick, Tipperary, Clare area. The physiotherapists in the community will take our patients also. So they take our patients and they'll even take them back twice a year, once, twice a year, or more if required. So lung transplantation is an option for some patients, and they can be sent to the Mater for lung transplant, and oxygen therapy. And oxygen therapy, again, if required for patients, we can support patients and educate patients on how to use their oxygen and what oxygen they need. There is not a one package fits all, so there's loads of different options, and we can support and educate patients with that. What can I do to maintain my physical and mental health? So basically, you can quit smoking if you're smoking, try and get plenty of rest at night time, keep up with family and friends, follow a healthy, well-balanced diet, and we would refer patients to dietitian to support patients with that. Try and stay active, practice relaxation techniques, especially if you get panicked when you get short of breath, and join a support group and help others with pulmonary fibrosis. And I think support groups are so empowering for patients and such a good thing. Now, we're unfortunate in this area, sometimes it's gone really, really well, and other times it's fallen apart. It kind of needs someone to take ownership of it, but hopefully we'll see it progress again in this area. But it is really important for patients, and patients really enjoy it. Will I need oxygen? I think as a patient with pulmonary fibrosis requiring oxygen, it can be a very daunting step for patients. It's can be for patients where they feel like their disease has really progressed and that they might be going downhill and downhill fast. That's not always the case. Oxygen can be to support patients so that they can live life to the maximum and have a good quality of life and get out and meet their friends and go shopping. So oxygen can be a good thing in management of the disease. It does help with reducing general breathlessness. It helps the ability to perform physical activity, and it can maintain the ability to perform daily activities at home also. The three symptoms that we hear about from patients all the time, and this is evidence-based also, dyspnea, cough, and fatigue. And cough has been described to be debilitating and violent, exhausting, and can cause other problems such as sleep disruptions. And there's little things that we can do to help and support that as well. Shortness of breath, especially on movement with this disease, more so when you're climbing the stairs, performing housework, in the shower, or talking. And fatigue, again, can be overwhelming. I know sometimes with patients, it could be because of the cough, but it could be sleep apnea is linked also. So it is important to tell us about your symptoms at home and how you're feeling at home so that we can help support those, and maybe do a sleep study, for example, and see that you need CPAP at nighttime. So there is other things that could be going on, or if your cough is bad, that we can just give you little tricks to try and help and support that cough. I've mentioned pulmonary rehab, so I just want to mention it again. Usually, and this is usually the same for anywhere around the country, it's an 8-week program where you're supervised by physiotherapist and a nurse. But you also get education sessions once a week in that, by a dietitian, by a psychologist, maybe by an end-of-life coordinator, and a respiratory nurse will go through maybe inhalers if you're on inhalers. It'll give chance for patients to debrief post sessions, and you get a final feedback session as well. And with pulmonary rehab, I think it's fantastic for patients. It promotes mental health. It does help improve body composition, increases your physical activity, and gives you confidence to exercise and move when you're breathless, which is really important. Exercise rehabilitation, to manage your breathlessness, and if you get very breathless in exercise, it helps you manage that also. It helps you to detect and manage acute exacerbations, which I presume the consultant will be speaking about. But if you get an exacerbation, we try and prevent exacerbations in patients with pulmonary fibrosis. So if we can detect and manage them earlier, if you're getting a chest infection, for example, we can maybe get a chest X-ray, get bloods done, start antibiotics and steroids sooner if required, depending on if you're getting an exacerbation or what the exacerbation is. Optimize pharmacotherapies, facilitate smoke cessation, and encourage patients to stop smoking, and maybe link with quit.ie as well. It's another fantastic resource that patients can link with, and establish social networks like pulmonary rehab, not pulmonary rehab, sorry, patient support groups, and advanced care planning and planning for the future. So this is just an idea of, again, with exercise being so important, patients really that get diagnosed with pulmonary fibrosis, their movement and their physiological symptoms and their breathlessness are increased. So with their exercise capacity reduced and their symptoms increased, their quality of life can be reduced as well. So introduce exercise training, then patients really see a difference in their cardiovascular, vascular, pulmonary and musculoskeletal physiology. They notice that they've improved their exercise capacity, which helps reduce symptoms and improve quality of life. So their health status overall has improved. So if you're not in pulmonary rehab, look into it in your area. This is a little study that a colleague of mine, Niamh Julian, who left us now and is in the Tipperary area, and I did patients post-pulmonary rehab that had pulmonary fibrosis, and just comments from them. It's a journey being diagnosed with pulmonary fibrosis. I haven't experienced anything like this before. The care in University Hospital Limerick is exceptional, but I think I would like more support from psychology. One talk is not enough. End of life talk in the pulmonary rehab also, it is not an easy topic. I was a bit uneasy about it, but I have looked at doing my will since. And then palliative care, the notion of palliative care being 6 days to expiry, it really is a palliative care, is a long journey, making you comfortable when you have an ailment. That for me was helpful. Obviously that was what the palliative care nurse said in her talk that day. So I just think it's important for us to receive feedback so we can improve our care all the time, because there's a lot of changes we've made in the last 10 years in how we support patients. And I'm always interested in having feedback on how we manage our clinics or our rehab so that we can improve care for patients and family members also. I really wanted to highlight this in my talk today because every patient I see, especially in the first, second or third visit, I will give them information, and a lot of information. This is not everything that ILFA have. This, like, what is pulmonary fibrosis, the treatment of idiopathic pulmonary fibrosis, oxygen and pulmonary fibrosis. The handheld fan is really important, and it can really help patients to relax with their breathing. It just gives that kind of the sense and the feeling in their face. It can really help relax, and it's a really good idea, and it's so small, so it can be carried in your handbag or in your pocket. And the ILFA medical alert card, if you were to get sick, it just gives you a little bit of information about who you are and your stall breathing technique, which is really important to know. So stop what you're doing, try to remain calm, assume a comfortable position, let your imagination take you to a safe place, and let your breathing return to normal. These are all resource packs that we give out in our clinics, and it's also a signpost for patients to be signposted to evidence that's real, not looking on Google and getting poor evidence or being kind of brought down a different road of a disease maybe that you don't have. It's bringing you to an area where this is true evidence, it's supported properly, you can link with ILFA directly as a patient and as a caregiver, and it's just very important information that's very true to what you're actually living every day. So it's invaluable for us to be able to give that to patients so they can read it after an appointment, because a lot of information in an outpatient appointment can be overwhelming. I wanted to just speak also about palliative care and symptom management. Palliative care over the years has changed so much. I think a lot of people think palliative care is end of life care, but it's such a different thing. End of life care is completely different to palliative care. Palliative care management is about managing your symptoms. So anytime I speak of palliative care to patients now, I would always say to patients, this is about your symptom management. And palliative care is a journey. It's a journey from maybe very early on in your disease to end of life care, but it's managing your shortness of breath, managing your cough, symptom relief with your fatigue, your anxiety, and maybe your chest discomfort. So it's assisting patients from spiritual support and patients and family members. Sometimes I think we forget about the family in a clinic where we're so involved with patient and managing a patient, and support for advanced care planning and goals of care discussions. And some people want to talk about those things and they need to talk about it in a very safe manner. And we're very lucky in Limerick where we have Milford Care. So we would refer a lot of our patients to Milford very early in their disease, and quite often they get discharged from palliative care if they're doing really well. But what they do in Milford, which is brilliant, is a breathlessness course ran by physiotherapists. So again, our patients have got the opportunity to attend the breathlessness course and go into Milford and get, again, little tricks of the trade of how to manage maybe their cough, breathlessness, and other symptoms. So I think it's very important that we know as a patient that there is other supports. So again, to try and be empowered to ask about those the supports. This is in getting ready for this talk. I was reading up more and I looked at the ILFA website and I saw the mindfulness and mental health resource pack with ILFA. So again, it's another signpost to what can support you at home. Like I said, you're not alone living with pulmonary fibrosis. So looking at weathering the storm, different mindfulness and stress controls. So it's just evidence-based links for a patient or caregiver to be directed to websites and supports that can help. When a patient comes in, and I've mentioned this, it's important for us as healthcare professionals to be open and honest with the seriousness of their condition and supports for the condition. Open discussions about the value of palliative care and team involvement in changing the face of palliative care, which I just mentioned, where we historically would have thought palliative care was end of life, and that's changing, and thankfully, and we now know again that it's for supporting patients and supporting symptoms. Spread and sustain, what I'm talking about here is patient support groups. I think patient support groups where patients and family members can support each other, because as much as I know about pulmonary fibrosis and supporting patients over the last few years, I've never lived with this disease. So patients that live with this disease every day, I have supports and tricks that they maybe do at home that can help and support another patient. And that, like, patients would regularly say that from pulmonary rehab and support groups, that shared experience has been really helpful. Sharing coping strategies, forming relationships with other people, other patients, other family members and charities. And exercise is not necessarily a part of the support group at present in Limerick, and it's me and Claire and Tipperary, but it can be in some groups, and I know some groups are doing it. And is this space more about meeting with psychological needs? It can be for us, but it can be psychological needs and exercise. It depends what people want. I just wanted to talk about us here in UHL and how we see our patients. So again, we educate and advise re-disease and antifibrotic medication, the 2 drug of choice that is there for patients. Again, I'm just wanted to reiterate the patients can look for supports. Regular outpatient visits we do for supports and education. We give our contact information to patients so that they can contact us if they need to contact us for a prescription or to talk about how they're feeling, or if they have GI upset, they can talk over the phone to us about that as well. And we can link them to the respiratory consultant then, because we have such a good relationship and close relationship with the respiratory consultants here. Patients in Limerick, in this area, 400,000 person area, so quite a big area. For example, if you're living in Milltown, Malby, you could be an hour and a half from Limerick Hospital. So Carmel McInerney and I started a respiratory polyfibrosis clinic once a month in Ennis, and I run the fibrosis clinic in Nina. So it's a hospital away from the major hospital that's near to patient's home. And Carmel McInerney and I again have done a research in the Ennis area of patients coming in. What they were saying was that they're using less oxygen because they had to travel less to their appointment. Because it was a small hospital, it was easier to park. Because it was a smaller hospital, it was easier to get to their appointment. So we'd reduce stress for patients. So I think that is fantastic if across the country that patients could be seen nearer to their homes. It does support the patient. And bring your loved ones with you for an outpatient visit, because secondhand information can be difficult sometimes. So again, we are happy to educate carers and family members also. And this is just my take-home message. Though pulmonary fibrosis brings its challenges, you're never alone in facing them. With care, connection, and hope, you can navigate this journey one step at a time together. So, thank you.
Paula, that was absolutely brilliant. Thank you so much. Really comprehensive and incredibly helpful. There's been a couple of questions that have come in, a couple that I can answer, and then we'll get one for you, but we'll need to be real quick. The first one, there was a lady that wasn't able to see the slides. So just to say, if you weren't able to see the slides, or if you didn't catch all of this, we are recording this session and we're going to be posting it up onto our YouTube channel after. So actually, I think, Paula, yours would be really good to kind of maybe sit with for a little bit and then come back and watch again, because I think it's one of those sorts of talks where you would just get different bits each time you watched it. So
Yes.
I'd recommend that folks watch it back. We've got a great presentation, Paula, that came in on the Q&A. So there you go. We also have somebody who's wondering, how do you get a patient care pack? I'm not getting them at my hospital. The answer to that one is, if you go to the website ilfa.ie, ILFA, Irish Lung Fibrosis Association, so ILFA.ie, you can register with us. And if you register with us, we will send you a patient information pack and an exercise pack if you'd like it as well. Now, here's one question for you, Paula. And you may, I'm not sure if you'll be able to answer this because it's quite specific, but I'm throwing it at you anyway. Is there a need to hold off taking OFEV if undergoing a tooth extraction or a surgery? What would you say to that?
I have seen this. For surgery, what we have done is held off. Yes, so I have a gentleman who had bowel surgery for something else, and Dr. O'Brien stopped the medication. But then it's for each patient. Each patient is individual, and it should be through their own physician, our own respiratory team, or if this person, man or woman, needs to speak to maybe their respiratory nurse to link to the respiratory physician, but it should go through if they're stopping their medication.
Okay, perfect. Thank you. That's excellent advice. Paula, once again, thank you so much. I really appreciate it.
Thank you very much.
Great. Our next speakers that we have on, Paula, I'll ask you to mute yourself and take yourself off video now, and then we will bring on the team of Anja and Aoife, Dr. Anja Schwekert and Dr. Aoife Carolan. They are researchers in Professor Killian Hurley's group in the Royal College of Surgeons. Anja's main research interest is the role of sex difference in pulmonary fibrosis, and she's been working in this space for about 4 years. Aoife is a respiratory physician that works with Anja there, and together they're working in the Living Lung Lab through RCSI. So over to you.
Hi, everybody, and thanks for the great presentation, Paula. You've made my job easier as I start. So this is, well, not everybody, but a lot of the people in the Living Lung Lab. It's getting bigger all the time, and it's run by Killian Hurley and Mario Zaki and Irene Ogilvie. And everybody on the screen here you can see is doing research into different questions around pulmonary fibrosis. And they're all doing some really interesting research, and what you're going to hear about today is just a flavor and a really small portion of all the work that's being done. So me and Anja are going to be talking about different angles. We come at the research from different views. Anja is a scientist and I have just finished my respiratory training. So we both have different perspectives on the research being done. And that's the nice thing about our lab group and a lot of the lab groups. It's doctors and scientists working together to try and answer some of the questions we have about pulmonary fibrosis. So as Paula already explained a lot of this, my job is a little easier, and I believe we're going to have a master class a little later. So to make it very simple, pulmonary fibrosis is scarring of the lungs. So there's an injury or inflammation to the lung, and then this heals abnormally. This causes the tissue in the lungs to become quite stiff, and this can make it hard for the lungs to breathe, and it can make it difficult for the oxygen to pass through from the lungs into the blood. So idiopathic pulmonary fibrosis is actually quite rare as diseases go. We call it idiopathic because we don't know exactly what causes it, but there's lots of things, as Paula was discussing, that increase your risk. So we believe it's kind of a combination of factors and the interplay between them, and different patient-specific factors like your age or sex, which Anja is going to talk a lot more about, or whether a person smoked or what their job was, and also their genetics. So we're all different, and the risks for one person is different from another. And sometimes even people that look the same on paper, the disease behaves differently. So we call it familial pulmonary fibrosis when a person with pulmonary fibrosis also has a family member with pulmonary fibrosis. So that's my area of interest for my research. So it's familial pulmonary fibrosis I'm going to be talking more about. So what do we know about familial pulmonary fibrosis? So the Irish Thoracic Society registry from 2018, about 1 in 5, 19% of patients with idiopathic pulmonary fibrosis reported that they had a family history. And so we know from research that's being done in worldwide that about 1 in 5 patients with a family history of pulmonary fibrosis will have a genetic component to their case. So the genes we're going to talk about are very rare. So there's 2 main groups of these genes. There's telomere-related genes, which I'm going to talk more about, and surfactant-related genes. So they're much rarer in adults. They can still happen, but they're more common in children. So I'm not going to talk about them as much today. So what is a telomere? So we've tens of thousands of genes in our body, and they're what make us different from one another. And they're tightly packed up in chromosomes, like you can see on the screen here. We each have 46 of them. And each time the cell divides, the chromosome has to unravel. And to stop it getting damaged, we have caps called telomeres at the end of the chromosome, just like at the end of our shoelaces, to stop the DNA getting frayed every time the cell divides. So naturally, as we age, our telomeres get shorter with the wear and tear of living, essentially, and our body has some mechanisms to protect it and keep it at a good length. So when it gets to a short enough length, the body knows it's time to retire the cell and it goes to sleep. So if we had a gene that's not working properly, that controls protecting these telomeres, it can cause a telomere biology disorder. So idiopathic pulmonary fibrosis would be one of the more common telomere biology disorders in adults, but these telomere biology disorders can also affect the liver or the bone marrow. So who do we test for these rare genes? So if a patient comes into clinic and they have a family history of pulmonary fibrosis, or if a patient already knows that somebody in the family has one of these telomere biology disorders, or they know somebody in the family has one of these genes, or if we suspect a person might have a telomere biology disorder. So that would be if someone went grey at a young age, that'd be in your 20s, and not just a couple of grey hairs, it'd be significant greying. or if somebody had a blood disease or a liver disease, among other things, we might suspect that they have a telomere biology disorder. And also, if someone was diagnosed quite young, before the age of 50, we might also suspect it. So in all of these cases, we would offer genetic testing in clinic. So how do we do a genetic test? So a blood sample is taken, and then this is sent to the lab, and then the guys in the lab extract the DNA. Then the samples from our center are sent over to Germany, and there they do some next generation sequencing on the DNA, and then they send a report back to the doctor who sent the test. So this can all take a few months sometimes to get the full results back, especially in complex cases. So what's my research about? So my main question is whether familial pulmonary fibrosis behaves any differently from people that have pulmonary fibrosis with no family history. And also we're looking at the rare genes in Ireland. So I'm mainly doing an observational study. And by observational, we just follow people for a year. We don't change their treatment. So a lot of the information I'm collecting is all the tests that Paula already talked about that everybody gets in clinic to monitor how their disease is going. So the lung function test, the pulmonary function testing, 6-minute walk tests. We do a CT scan at the start and at the end of the year. We also get a lot of the bloods that Paula was already talking about, as well as taking some extra samples for research. We're also monitoring people's lung function at home, as well as their oxygen saturations at home for the year. So a lot of this work is still happening at the moment. So unfortunately, I can't give you all the results today, but hopefully by the end of next year, all of it will be finished. But I can tell you a little bit about some of the things that we found. So we found that patients with a family history appear to be younger in our group, which does seem to line up with what we know from research that's been done elsewhere. So the average age of the familial patients in my study is 68, whereas people without a family history had an average age of 75. Then something Anja is going to talk to you more about is that half of the patients with a family history in my study are female, whereas in idiopathic pulmonary fibrosis, only a quarter of the patients were female. So in our study group, from all the genetic testing we've done so far, approximately 20% or 1 in 5 of the patients had a genetic finding, and then 1 in 8 of the patients that are taking part in the research had a genetic mutation which we think has contributed to their pulmonary fibrosis, so that it's a big risk factor for why they had pulmonary fibrosis. And now Anja is going to tell you more about her research.
Great. So I'm gonna change the topic a little bit because, as Aoife said, I am a researcher, so I am working in the lab. And Aoife already said that in our lab we are a lot more people now, so we are looking at different aspects of the disease because we don't really have a cause for idiopathic pulmonary fibrosis. We have different causes that are associated with the disease. But if we better understand why some people get the disease and others with the same exposures might not get the disease, that will also help us to understand the disease and hopefully find new medications. And as already mentioned, I am very interested in the effect of sex differences in pulmonary fibrosis, which is one of the causes associated with pulmonary fibrosis. And if we look at as Aoife pointed out already, at the patients that have pulmonary fibrosis, in our clinic, 25% of these patients are female. And this is in line with the literature where also between 30 and 40% of the patients with idiopathic pulmonary fibrosis are female. So what could be a reason for this difference? Why do more men get pulmonary fibrosis? So this is what I am trying to investigate, to figure out. And let's just look at what are differences between men and women. So when we look at the lung size, men have bigger lungs than women. And then in addition to that, there are also sex hormonal differences. So sex hormones, the main male sex hormone is testosterone, and the main female sex hormone is estrogen. And these hormones play several roles in the body. So, for example, testosterone plays a role in facial hair growth, in muscle strength, in the generation of red blood cells. And estrogen is also playing a role in the menstrual cycle and cardiovascular health. And we call them male sex hormone, female sex hormone. However, it's not that easy. So although we call testosterone the male sex hormone, this means that testosterone is the sex hormone that is the main sex hormone in men. However, men still have also estrogen, and the same is the case for women. So estrogen is the main sex hormone in women, but they still have some testosterone. And my research is interested in what is the effect of sex hormones in pulmonary fibrosis. So how can we look at that in the lab? If we just look at what region of the lung is affected by pulmonary fibrosis, it's the lower part of the lung. So that means we can't just take cells from a donor or a patient and use them as a model in the lung, in the lab. We need some kind of model, and what we are using are these lung cells that we can generate in a dish. And I'm going to tell you now how we can do that, because it's like a really, really cool process. So what we can do is we can take blood cells from a participant, as in from a patient or from a donor, and we can generate adult stem cells from them. So these are called induced pluripotent stem cells, and they actually have the genetic background of the donor. And that means, for example, if we are looking at a pulmonary fibrosis patient and they have a mutation that might be associated with pulmonary fibrosis, we can make their stem cells and we can then have a look at them in a patient-specific manner. However, I'm talking here in this talk now about idiopathic pulmonary fibrosis. So what we are using is just from a healthy donor, like a non-deceased donor. We are using blood cells and we generate these induced pluripotent stem cells. And these induced pluripotent stem cells, they're really tiny cells. And when we look under the microscope, they look like this. They are like little patches of cells, but they are really amazing because those patches of cells can actually become every cell of the body. So here are just two examples. So on the left, we have heart cells that were generated from these cells. So they're generated in the lab by researchers and they can actually beat. And then on the right, we have our lung cells. Those are the cells that we are generating from these induced pluripotent stem cells. And this is the model that we are using to investigate our research questions. And these cells, as I said, are healthy. So when I do an experiment, I want to induce fibrotic changes. So I want to injure them so that they behave like the cells in a patient. And I can do that using a profibrotic cocktail. So the profibrotic cocktail, although it says cocktail, it doesn't contain alcohol. It's a mixture of chemicals, and those chemicals induce fibrosis. So they induce the injury. And different cells react differently to this cocktail, to this mixture of chemicals. So after treatment, we get like these different cell types. And what was really interesting, that when we did this experiment, we found a cell type that only occurs in the lungs of pulmonary fibrosis patients, but not in healthy lungs. And we found that in our lung model, so the one that we are using in the laboratory, which also assures us that the model is actually really close to the human, like the human lung, or the human lung cells. And then I was saying I'm interested in the role of sex hormones. So what happens if I add testosterone in this mixture? We found something really interesting, because if we added testosterone in this mixture, we got more of this pulmonary fibrosis specific cell type. And that kind of hints that testosterone, so the male sex hormone, pushes cells to become the cell type. So what can we do with this information? So all of us in the lab here, we are trying to understand different aspects of the disease better. I'm like me myself, I am looking at, or I'm interested if the treatments might have a different effect in men and women. And all of this information together can then hopefully help us find new medications. And with this, I want to thank you for your attention. And I'm just going to point out, like, we are a big lab, so we are a lot of people working on this and just trying to figure out how pulmonary fibrosis is working. But yeah, in the lab we are working, a lot of us. So these are all our members. So thank you.
That was absolutely fascinating. Anja and Aoife, thank you so much. We have a vote of confidence for you. So as a telomere biology disorder patient, I'm so glad to see that this is being discussed. So well done there. We've got some folks on the call that are affected by this. So your research is incredibly important for many reasons, that being one of them. And a question of, can stem cell, helps if I say it right, can stem cell treatment help with ILD?
That's a good question. So we are not really looking at using stem cells as a treatment. We are really looking at using stem cells as a model to understand the disease better. So I can't really give you an answer to that. It might be, it might not be, but at the moment, like in our lab, we are looking only to use them as a model.
Okay. Well, as I said, that was absolutely fascinating. When Anja, when is your research going to be? Aoife was talking about her conclusions coming kind of the end of next year, maybe. When's your research finishing up?
Well, so I have like now more people are looking actually at the sex differences in pulmonary fibrosis, but we started really, really early. So we are at the moment basically just kind of starting the whole thing. So my research project itself hopefully will finish by also middle or end of next year. But there's so many things that are just not known at the moment. So like once we have an answer, or when we have an answer to the question, I think that's another topic.
Okay, great. Well, that's great. We'll just have to have you back at the end of next year for the updates on both of yours. Well, there's no more questions that have come in for you. So I think what we'll do now is go ahead and move on to our next bit, which is actually a little break. And the next space in our agenda is going to be for a quick update on ILFA activities. You heard in particular, Paula did a great job of outlining many of the activities that ILFA conducts on a regular basis. I want to highlight some of those and then talk to you a little bit about what we've got upcoming in 2026. So it's exciting times here, and I'm just going to once again share my screen. Okay. Comfort break slide. Okay. So ILFA, in ILFA, we work across 4 pillars. Our 4 pillars are education, advocacy, research, and then the direct support services that we provide to folks. Sorry, I had to get rid of that box. And just to give you a little bit of an update on each of those that we've been up to this year, in terms of advocacy, it's been an extremely busy year. So the end of last year, there was historic funding that had been allocated for lung fibrosis in budget 2025. There was 500,000 that had been allocated in 2025, and then another 500,000 for budget 2026. So at the start of the year, we met with the HSE and the Department of Health on what that funding would be spent on to ensure that it provided the most benefit for lung fibrosis patients. There was a little bit of a delay, though, unfortunately, in getting that funding released. And in March, when we still hadn't heard anything, we started to get active in the advocacy space, putting in parliamentary questions, talking to politicians and just attempting to get the funding status and then the funding released. In June, we had a very big strategy launch that we had done. It was an organization called Prospectus that do a lot of strategies and reports. They had developed a strategy for equitable care for us. They've done some research, discussed, the inequities of care that we have here in Ireland with patients, the medical community, and others. And from that then came this groundbreaking report. That was launched in June in the AV room in the Dáil, and we had great turnout from the TDs and senators on that. That helped provide a North Star or a pathway forward for lung fibrosis care. That pathway needs to be funded though. So in July, we did another pre-budget submission where we said lung fibrosis patients needs X, Y, and Z. Once again, we asked for about 5 million euros. We'd done that the previous year as well. And then in August, when the funding that had been allocated still hadn't been released, we went and we were able to fortunately get a meeting with Minister Jennifer Carroll McNeil at the end of August. And we met with her, we met with the HSE and the Department of Health in that meeting, and that seemed to unlock, if you will, the barriers that have been put in place around that funding. So the funding is now in the process of being released, and we are working with the HSE to put forward projects and proposals for where that money is going to be spent. And it's actually quite exciting, and I wanted to talk to you a little bit about that. Before I do that, though, we'll just say the other advocacy activities that we did in September. We had our Lung Fibrosis Awareness Month. Maybe you heard the radio ads, maybe you saw the news stories. It was absolutely brilliant. We think that there were 5 million messages that went out across Ireland, and we hopefully got to over 1 million people that heard about lung fibrosis, that knew the signs, and then were able to go to their GP and get diagnosed if they needed to. Those events culminated on the 25th of September, which is World Lung Day, where we had a big event in the morning, once again over at the Dáil, and then in the afternoon, we did a fundraiser with the central bank that was a lot of fun in Dublin. So then just in terms of where we've been going after that and where we'll continue to go over the next couple of months, we're continuing to get the funding negotiations sorted out, and hopefully those 2026 priorities in place. And in terms of our own advocacy work that we're going to be doing in 2026, we really want to work on sustainable funding. That's really important. We did have money allocated in 2025 and then also in the 2026 budget, but what about 2027? What about 2028? So we need to ensure that there is sustainable funding in the government's budget every year for lung fibrosis care. So that's one of the things that we're going to be advocating for. We continue to advocate for a disease registry. We don't know how many people in Ireland have lung fibrosis. We think it's around 5,000, but it could very well be many more than that. There is some work that's being done by the clinical advisor, which is a role that was put in place in June of this year. So that's great. And part of that work is trying to understand how many people have lung fibrosis in Ireland. But what we need is a disease registry from an ongoing basis. And then we have transplants as well. So we'll continue to advocate for an increase in lung transplants in Ireland. Affordable care, that's a big one, reducing out-of-pocket costs for people, making sure that everybody has medical cards that needs them, making sure that, for example, the electricity costs that you have to pay to run your oxygen concentrators, that gets reimbursed for you. So there's work that we're doing as well there. And then our ultimate goal, equitable care. And the way that we get equitable care is through a clinical program. So we will continue to advocate for equitable care and a clinical program. So that's what we're doing in the advocacy space. Then in our next pillar in education, we've done a lot of educational events. These patient information days that we're doing, this is the second of our 2 for this year. So that would be part of our educational work. We also have deeper dives that we go into in specific topics. Those are called our Let's Talk sessions. We've had 7 of those so far, and I believe that we're scheduling one, hopefully before the year is out, that will be about pulmonary hypertension. So that should be very interesting, and hopefully you'll be able to tune in. All of these videos, the patient information days, the Let's Talk sessions, they're all uploaded on our YouTube website. So if you go up to YouTube and you look for ILFA, you'll find our channel. And as I say, like and subscribe and watch the videos. We have our ILD study day for healthcare professionals. That's something that we do in conjunction with the Irish Thoracic Society. We've been doing that for many years. It's an absolutely brilliant event that comes in February every year, and it'll be once again in 2026. And then our patient public involvement group, our PPI. So that's work as well. And in addition to that, in 2025, we also added a bunch of offerings around education. We had a breath and resilience course that folks could take, that we were looking to improve quality of life indicators for the folks that participated. And from the research that we had, it did come back that folks had improvements of several factors of their quality of life after having participated in those creative resilience sessions. We also did a mental health training day for health care professionals this year. That went off really well. We've got mindfulness courses. Now, we've been running those for the last couple of months. We'll continue to run those through the end of the year and then into 2026. You can still sign up for the mindfulness courses. They're 6-week courses. They're absolutely brilliant. We're getting great feedback out of them. So do sign up. Contact Kelly at info@ilfa.ie to sign up for those. We did a GP mailer earlier this year. We've done that. We've sent that out twice to the GP practices across Ireland so that they can understand what is lung fibrosis and be aware of it when a patient is coming to them so that they can consider that as a diagnosis. We did a clinical trials mailer for folks. We sent that out to all of our member community, and it taught people a little bit about clinical trials, the clinical trials that are out there, and why you might consider participating in a clinical trial, helping the research that is ongoing for lung fibrosis. And then we've had many publications in the Irish Medical Journal and other journals this year. So we've gotten a lot of our previous work, our previous studies published in medical journals. So doing a lot of work in education and research this year. And then in support services, now this is a short list, but it's a massive part of the work that we do. And these are some of the things that Paula had talked about. She said, you know, that exercise is so important. And ILFA at the moment, we're offering 3 exercise classes per week. So those have great attendance, but we would love for more people to participate in those. They are truly a community of people. And it's such a great way to get fit and stay fit. So if you'd like to participate in the exercise classes or really in any of these activities, if you send an email to info@ilfa.ie, Kelly will be able to help you out. We have our patient non-medical advice line. So patients call, they have queries, we're able to answer those. We try to give the best advice that we can there. We have information packs that we sent out. You saw Paula, all the little flyers that she had on that one slide. That's an example of an information pack. We also have exercise packs that we started giving out in 2025 to go along with those, thanks to some funding, which was brilliant. We do an ecumenical service every year in October. That just happened a few weeks ago. Incredibly moving, really, really wonderful event. We have support groups, and we're adding them all the time. So the latest support group that Gemma is going to be adding on is she's looking at getting a virtual support group established. So for people where an in-person support group isn't convenient, we're hoping that you'll be able to join the virtual support group and have a community of like-minded folks that you can talk to. They are incredibly helpful, again, as Paula mentioned. And then we had an August yoga session. So Emer was taking a little bit of a vacation there in the summertime. She's our exercise lead, and so we had some substitute yoga classes that happened for a few weeks' time, and we're trying to see if we can get some yoga classes for the Christmas time again as well. So yoga is really popular, and we want to go ahead and continue that as well. So that's what we've been up to in 2025, and it's an expansion of our services from 2024. And once again in 2026, we're looking at doing even more for our community. And what we'd like to be able to do, these are all kind of funding pending sorts of activities. We want to offer Sing Strong again. We offered that a few years ago. It was really well attended, really well thought of. And again, that goes back to that exercise. This time you're exercising your lungs and you're doing it through singing. So a really inspiring, creative, and helpful sort of a class. Breath and Resilience 2.0. So we'd like to offer that again in 2026. The big news is, and this again goes back to that point that I was making around the advocacy work that we've been doing and that funding that was issued at the government level, and we're hoping to unlock. We're in conversations right now on having a few new services that would be funded through the HSE. One of those includes a nursing advice line. So the ability to be able to call ILFA and, now we can offer, non-medical advice. We would be able to offer nursing advice in addition to that. So that would be amazing and wonderful uplift in the work that we're doing. In addition to that, and once again, you heard Paula talking about the importance of pulmonary rehabilitation. The unfortunate thing is that in a study that we did a couple of years ago, 75% of lung fibrosis patients were never offered pulmonary rehabilitation. We want that to end. We want everybody that has lung fibrosis to be offered pulmonary rehabilitation. We understand that it might be difficult for you to be able to travel to a place where that you can get it, even if you are offered it. So what we want is we want to offer virtual pulmonary rehabilitation. We're trying to prove that out with a pilot next year. And if that pilot proves itself to be successful, then we will be able to expand those services and be able to provide virtual pulmonary rehab, hopefully to everyone that has lung fibrosis in the future. Mental health is also an increasingly important topic. And once again, you heard Paula talking about that, the importance of self-care, the importance of kind of taking all this information on board. It can be actually really, really difficult and challenging. And so what we are trying to do is offer a mental health counseling grant that families would be able to avail of up to 6 sessions of mental health counseling. We are also hopefully then going to be offering 2 more exercise classes per week. So instead of 3, we'll be doing 5. And then, as I mentioned before, pulmonary hypertension, providing a little bit more information about this disease that coexists and coincides often with lung fibrosis. And then also, we're looking at events, maybe having some additional in-person, perhaps virtual events in 2026. So that's what ILFA is up to. And I would like to, at this point, stop sharing my screen. And I think I'm going to turn it over to, yes, we have Adam Byrne. He is with us. Adam, you're very welcome. If it's okay, I'll do a quick little introduction for you, and then you can start sharing your slides. So Dr. Adam Byrne completed his undergraduate studies, Professor Adam Byrne, actually, sorry, completed his undergraduate studies in chemistry at the University College Dublin and subsequently undertook a PhD in medicinal chemistry at Trinity College in Dublin. After a period in industry, he carried out postdoctoral work at Northwestern University, Chicago. Ooh, that's where I used to live. And the Kennedy Institute of Rheumatology, University of Oxford. He subsequently moved to the National Heart and Lung Institute, Imperial College London in 2014, and joined the academic staff in 2016. In 2023, he was appointed as a full professor of respiratory immunology at UCD, a Conway Institute senior fellow, and a senior fellow at the Imperial College London. His laboratory explores molecular mechanisms that dictate innate immune responses in the lung during chronic lung diseases such as asthma and idiopathic pulmonary fibrosis. So you are very welcome, Adam. Thanks very much for being here.
Thank you very much. Hopefully you can see my screen.
We can now. We can see your whole screen. So
perfect.
Okay, now we see your slides in presentation mode. You're good.
Great. Okay, well, thanks very much for the opportunity to present. It's a wonderful opportunity to share the kind of stuff that we're doing in my lab. as you just heard, I'm interested in lung inflammation. I'd say 45%, well, maybe about 70% of the work that we do in my lab is focused on IPF. We also look at other rare respiratory diseases, such as children's interstitial lung disease, which I'll talk about a little bit later on, um, but also things like Dipnic and other ILDs, like hypersensitive pneumonitis, that you may have heard of. Um, so let's see if I can click through. So, as you just heard, I'm interested in understanding the roots of lung fibrosis, and we try to study IPF at the cellular level. Oh my goodness. Hopefully you can see stuff. Yeah. So as I was leaving in the last couple of years that I was at Imperial College, we actually established the first ever lung fibrosis center. I think it was the first of its type in the world. So this was the Margaret Turner Warwick Center. So she was one of the first people to take IPF research really seriously at the Brompton Hospital in London. So she's world renowned. So the center was named after her. The idea was to really start bringing people together because we realized we had a critical mass at Imperial College of people involved in IPF research through our connections with the Royal Brompton Hospital is situated really, really closely to Imperial College, the National Heart and Lung Institute, where I was. So this is where I got interested in lung fibrosis. I was interested in asthma, but actually it was just a really interesting from a clinical need point of view, but also from a scientific point of view. It's a disease I really wanted to work on, and we got great patient samples from the Royal Brompton Hospital, which really helped our research. And then I moved in 2023 to the Conway Institute. So less work was being done in the Conway Institute and IPF, so very little to be honest, but amazing patient engagement at St. Vincent's Hospital. And I connected up with a respiratory consultant, Cormac McCarthy at St. Vincent's. So the two of us really tried to establish a research group trying to uncover some rare diseases, but also the fundamental mechanisms understanding lung fibrosis. And then maybe once we do that, we can start to translate our work to the clinic. So that's the ultimate aim. But I'm a basic scientist and I work at the kind of fundamental understanding of why does IPF happen? What's going on in the lungs? Can we prevent it from happening? But also once we understand the mechanism, joining the dots of how the disease works, can we try and interrupt it and come up with new therapies? So I always argue that the lung is a really unique organ to. Sorry, I'll try and get this out of the way. I don't seem to be able to do it. Just do that. It's a really unique organ to study because when you think about it, it's an internal organ, but it's constantly exposed to the external environment. So this is a picture of a healthy lung. So this what we do is we actually embed a piece of tissue in paraffin. And so we can slice, so it hardens and we can slice through it and then we dissolve out the paraffin. We've got this nice thin slice of an airway that we can look under a microscope. Oh, why this is all jumping around. Sorry, everybody. So this is a healthy lung. So what you really want in a healthy lung is these very thin walls. So this is so gas exchange can take place. So remember, we're slicing, it's like we're slicing through a sponge. If you had a very thin slice of a sponge, this is kind of the structures that you would see underneath a microscope. So we have some blood vessels here, but this is the walls of the airways essentially, and they're nice and thin. So the airways are, like I say, are constantly being exposed to this. We want to keep this nice and thin lung, but airways, but we also want to be able to effectively respond to things that are inhaled, like threats that we might inhale. So things like cigarette smoke, and we're always exposed to pollution, allergens. We all know about COVID, and one of the surprising things from COVID is that there is potentially some long-term fibrosis in some patients as a result of COVID exposure. We also have bacteria. We have bacteria that live in our lungs happily, and we have some that might cause the disease. And I also study some allergens like house dust mite. So I'm really interested in what cells and molecules decide whether to respond to these inhaled threats. Because if you clog up these airways with immune cells mounting an immune response to a challenge or something that you might inhale, you might end up clogging up these airways and making it difficult to breathe. But conversely, you want to be able to stop whatever's being inhaled. And sometimes the immune system gets it wrong, and I think that's what happens in lung fibrosis. So in lung fibrosis, this is a fibrotic area of a lung, and you can see these small, thin airways have been densely packed with collagen, principally, or parts of collagen, and a cell that lays down that collagen matrix called a fibroblast. So I'm really interested in how the immune system responds that leads to this, and can we reverse it? So as I say, the lungs are a very delicate organ. They're under constant blood supply, obviously, because you want blood coming in and you want CO2 going out again. So you need constant blood supply, and there are these delicate sacs, the airways, and that's where the lung injury happens. So the slide I just showed you, it would be if you were to slice through these sacs to see what they look like. So I say in lung fibrosis, we get a complete change in the way that the lung looks. So this is a CT scan with which you might see. So this is looking down onto the lung, and this is the spine here, and you can see that there's honeycombing. So it's an unusual kind of restructuring of the airways, and we call this honeycombing here. And there's some normal areas, and then you can see some areas of lung fibrosis. And again, this is another patient and what it looks like. Again, these thin airways have been densely packed with collagen. So we want to try and understand how this happens and what can we do about it. So if we talk about IPF, I know you know about this, but it's good to discuss what happens in fibrosis. In the UK, where I was always based, there were 6,000 new cases annually. I don't think the data is as good in Ireland. Obviously, it's going to be a lower number, but as a percentage, about the same. And there's poor survival rates. And how we think IPF happens is a mixture of genetic susceptibility and the environment. So there are some genetic changes that we know are associated with lung fibrosis. Changes in how the cells divide. The spindles from when the cells divide are shorter in some patients with lung fibrosis. There's been some genetic changes in mucin, how the body produces mucin found. But the major kind of driver is this environment exposure. So we think it's a mix between this genetic susceptibility and the environment. So you have this complete remodeling of the airways, like I showed you. So what we think has happened is that the cells that line the airways are these alveolar cells, or the epithelial cells. And we think in a susceptible individual, so somebody has some genetic susceptibility, and then from their environment, whatever it might be, particulate dust, or maybe some smoking, or something, or some other triggers that we may not even know about, there's damage to these cells. And what should happen is that you get that being repaired. So that should effectively repair. But for some reason in lung fibrosis, what we have is this repair leads to activation of these fibroblasts that are around in the tissues. This is the airway side where the air comes in, and this is the tissue side underlying it where the fibroblasts are, and they start to lay down collagen matrix. And we think that the immune cells mediate that crosstalk between these cells that should be repairing and the cells that lay down collagen matrix. And it's kind of like a thickened scar. So if you get it in your skin, wound healing is a good thing, but in the lung, you want that thin diffusing space, so where oxygen and carbon dioxide can get across. You don't want anything in between it, and that's what happens in lung fibrosis, and it makes it difficult to breathe. So one of the major associations with lung fibrosis is aging. So the mean kind of around the average age of somebody who's gets diagnosed with lung fibrosis at about 65 years. I mean, it can be younger and it can be older. There's limited therapeutic options, and I think that the drugs that are available are imperfect, but they're the best ones that we have. And there is some side effects of them, which I'm sure some of you know about. So it's really important that we understand these mechanisms so we can come up with new therapies. So the first step in coming up with new therapies is understanding the disease. And one side, there has been some good news from clinical trials with a new a new potential option in IPF. So there's a very positive clinical trial, and it's a new FDA approved therapeutic. Now, I don't know when it's going to be getting to Ireland, but it's been improved in the US, and there's a lot of steps now, regulatory steps before getting it here, but it's positive news. And actually, the person who led that trial was a person I used to work with at the Royal Brompton Hospital, Toby Marr. So he was here a couple of weeks ago, and I got the chance to talk to him about it, and he's quite excited about it. So the cell that I study that lives in the lung space is a white blood cell called airway macrophages. So they are known to be really interesting in other tissues, in the skin and things, in dictating the responses between health. And then when you get challenged in different tissues, whether deciding whether to go for repair or to kick off inflammation to deal with the threat. These are cells that live in our airways. They're the most abundant cell, immune cell in the lung. And they are the first to see something that is inhaled. So I was always really interested in whether these macrophages can make those decisions between staying as things are, as a healthy lung, or to kick off repair or kick off inflammation. Or repair is the kind of side of the coin that we're really interested in terms of lung fibrosis, but inflammation can also be connected to that. The main thing that the macrophages do, their macrophage means big eater, and what they do is they literally ingest things that might get inhaled in, so particulates, bacteria, smoke, pollution. So they do this by a thing called phagocytosis, where their cell membrane reaches out around things that come in and gobbles them up. And when they get internalized, that's when it makes the decision. It says, is this what I just ate, is this a good thing or a bad thing, or should I kill it, or should I go start calling in other immune cells to start to deal with that threat? So they do lots of things once they get activated, once they ingest these particulates that come in. And I've done loads of work looking at these different. So this is the alveolus, so this is the lining of the airways again. And these macrophages, if you look at them, they're right up against those alveolar cells. So this is where the injury takes place in lung fibrosis. And this is the tissue side where the fibroblasts start laying down collagen. So I think it's this crosstalk between these immune cells and the epithelium that ends up kicking off repair. So that's what I'm really interested in. You can also get them coming in from the blood. So these live for a long time in your lungs, but work from my lab has shown that you also get them coming in from the blood, and then they change into macrophages. So what do we do with our samples from lung fibrosis patients? Sorry, my clicker keeps jumping around. I think there's something going on with my slides, but I'll keep an eye on it. So we get, if I can, sorry. Hopefully it stays here. So what we do with patient samples, when people are good enough to consent, whether they're getting a bronchoalveolar lavage or a blood sample being taken, our entire research program is based upon people being kind enough to share their samples with us and trusting us to do that. And what we get from these samples could be just a blood sample, an additional blood sample. 5 mils of blood will tell us huge amount of information. Sometimes we get bronchoalveolar lavage, and we can get the cells from the lung from that. That's really, really important that we get cells from the lung, because fibrosis is principally a lung disease. So to understand the disease, we really need to understand what's happening in the airway. So we get these bronchoalveolar lavage samples. Sometimes we get brushings if it's clinically indicated, if it's needed. So brushing of the walls of the airways, and from those we get those epithelial cells. So in the lavage, we'll get the macrophages, and these brushes will get the epithelial cells. And if we want to look at the fibroblasts, which lay down the collagen, we need to look at tissue, so chunks of tissue. Oh, goodness. And then from those, we can embed them like I showed you and slice them and see what's going on in the lung. Or we can grow those fibroblasts in the lab, and we can add therapies on top, or things that we think are helping or not helping lung fibrosis. And then when we get all of these things together, we can actually start to reconstruct what's happening in the airways. We can put them in culture together, and then we can control the variables, and we can start to do really interesting experiments. So things that we do are things like metabolic assays, just because metabolism is really, really important to how cells behave. And I've worked on projects looking at how metabolism of macrophages is really important. What fuels their function? Where are they getting the fuel to be able to go and drive inflammation or wound healing? So that we have instruments that can measure that. We can measure metabolites that might influence that. I'll tell you a little bit about flow cytometry. We can tell about all the immune cells in really, really small detail about what happens in those airways. And then, like I say, we can make ex vivo cultures. So we can, for instance, put the epithelial cells here on top. We can put the fibroblasts in there, and we can put the macrophages in here to see what they do to the epithelial cells, to see what they do to the fibroblasts. And in that way, we can really control all the conditions. And then we also do some imaging, and we can look at these fibers here are ways we can image collagen fibers. So one of the important things about IPF is not the amount of collagen sometimes, but how it's organized, because they're in really long fibers. So understanding whether we can reorganize collagen is really important too. So that's another thing that we look at. So what do we do? Well, we do flow cytometry, which is a way to measure all the immune cells in one go. And we're really good at that, I have to say. My lab are great. So we've set up all these methods here. So we essentially, you can tell cells apart by the proteins that are on their surface. So we actually label them with different colors, and then we can look at, using that, we can figure out what immune cells are actually in the lung. This is cool stuff. This is stuff we've done from bronchoalveolar lavage. We've put macrophages on one side. So how they move is really important. Whether do they get called into sites of fibrosis and inflammation? And in this experiment, we've put something that tells the macrophages to come over here on this side and the cells over here. So these dots I've added artificially, these are cells. These things here are cells. And we've been able to, with this type of experiment, we can measure, are these cells going in a direct line and they really want to come across like they should do effectively? Are they getting stuck or getting lost, or are they going off to the side, which they shouldn't do? They should come in a straight line, or do they start wandering off? And these are things that we start to understand about their behavior. We can take images of the lung, and then we can stain all the different immune cells and see where they're arranged. So you can see like the immune cells aren't random. They arrange themselves in different organizations. So we can see in really great detail how the different immune cells, if we color them in different things, where they arrange themselves. And then we can do things like, this is an experiment where we've labeled the DNA in the cells in red and yellow, and we've challenged the cells outside the body. And what some macrophages and other cells in the immune system do, when things are too big for them to be able to phagocytose, to eat, like I showed you, sometimes they do a really clever thing where they take their DNA, instead of just using it for, defining who they are, they use it as a net. So they literally throw out all their DNA to grab stuff. And this is them doing it when we've been able to label this. These are cells from IPF patients, put in something big there, too big for them to eat, and then they decide they don't like it. And then they start shooting out webs to see if they can, oh goodness, see if they can capture this essentially. So they start trying to shoot out their DNA to try and capture that, to reach that, to inactivate it essentially. And they do a great job of it. We also measure DNA. We want to understand the underlying things that are different in IPF. These might help with diagnostics actually. So there are things, because one of the things with IPF is being able to diagnose it before you can even treat it. So that's a difficult thing to do. So we try to do that also. So stuff that we work on, we've done, these are things that we've published. We found new predictors of disease. So we found a protein that's increased in the lungs of patients. And if you've got lots of that protein, the outcome for IPF is not as good. This is survival compared to patients who have low levels of this protein. So we're thinking about this as a potential marker of disease progression. So if we can measure it, we can see how the disease is progressing. I've been really lucky when I was in the UK to be funded by Asthma and Lung UK. And don't tell anybody, but I've been funded by Research Ireland to continue this research. We found a metabolite in that only macrophages make to be present in the lungs of healthy people, but it was gone in IPF patients. We couldn't detect any of it in the lungs of IPF patients. And when we took that metabolite and put it on top of fibroblasts, it stopped it from laying down collagen. So we think we may have discovered a antifibrotic metabolite. So we're working on how to weaponize this, essentially change its features, change its structure so we can turn it into a drug. So we're working really hard on that. Another thing we work on is competition for nutrients, and one thing that macrophages are really good at is iron. So iron's everywhere, particularly in pollution, and we found that macrophages in IPF patients can't eat iron like they should. So what if iron isn't eaten, it can feed bacteria and they can divide in the lung, or they can activate the fibroblasts, or they create reactive oxygen species so they can cause damage in the lung. So we thought that's maybe one way that iron can cause damage because the macrophages are failing to mop it up. So we're working on that right now. And that's funded by the Wellcome Trust. And we're also, the Wellcome Trust in the UK have funded me to see if we can stop. I mentioned metabolism is very important, how a cell gets its fuel. There are currently drugs that can change metabolism of cells that are FDA approved, and I'm wondering if we can use them to switch an angry macrophage back to a healthy macrophage. So that's a large project that I'm working on now. We're really hoping that we can repurpose drugs that are currently available to use in IPF. So that's a major focus. And I've been working on interstitial lung disease for quite a while, and then unfortunately my nephew got diagnosed with a childhood interstitial lung disease, a really, really rare disease. It turns out it was one of the ones that kids grow out of, which was great. But the one thing when my family were asking me about childhood interstitial lung disease, I realized that there's just absolutely nothing being done about it. There's very little information out there about how childhood interstitial lung diseases happen, and if they do grow out of, what happens to them when they get older. So I'm working on a project where I'm using the most high-tech techniques I can get my hands on to use old samples that are in the basement of the Brompton, actually, that nobody been looking at for years. But we can resurrect them and we can look at all the things that I described to you. But also we're getting patients who had childhood interstitial lung disease to come back in, give us a blood sample, and we can compare them to current patients with children's interstitial lung disease. And that's funded by Asthma and Lung UK too. So one thing to say is just we're really grateful for the interactions we've had with patients and the support of patients have with shaping our work. It's critical to everything that we do. So I really encourage you to engage with us. We'd be delighted to talk with you, because lived experience really can help shape our research. And we have assumptions, and with the best will in the world, I'm not a patient. Not with the best will in the world, but I'm not a patient. So there are assumptions that I may have, and your input can really help with that, especially with experience of IPF symptoms and your experience with treatments. And you can tell us what matters most to you, and we really, that would be really helpful in shaping our work going forward. And there are also challenges with patients that our research might overlook. I'm very focused on therapy and mechanism, but there could be other things that we could be looking at. And one thing that really helps us is when we're applying for research funding. Now we're competing with people who are doing completely different diseases, and we have to advocate for lung research and lung fibrosis research. And being able to get funding is so critical to be able to do the proper internationally competitive research that hopefully leads to therapies. And so when we design projects, it's really important for us to get patient feedback on study designs, the consent material that we put together, and what makes participation easier. It really helps us design our grant applications and then implement, if we are lucky enough to get funding, to be able to make things run smoothly. So input on that is really important. And any suggestions or new ideas or questions we haven't thought of is always really welcome. So I'd like to thank the patients principally, and I'd also like to thank my collaborators, but this is my research team. We've gotten out of control. We're starting to grow really quickly. This is Cormac, who some of you may know, who I work with really closely on the patient side. And these are all our MD fellows, PhD students, research assistants, and people and technicians who really help our research flow. So thank you very much for your attention, and I'm happy to take any questions that you may have.
Thank you, Adam. So we're going to hand over to David, who is our patient story for today. David, I think that you're there in the background. Hi,
Yeah,
David. So David is a great advocate for ILFA, and he's joined us today to share his story. So thank you, David, and I'll hand over to you.
thank you very much, Kelly and Adam. That was very interesting, especially someone in my situation who had two brothers and a sister that passed away with IPF. So I was very interested in all your slides and a lot of great information. And also it's powerful information from all your researchers and speakers today. It was valuable information for people with IPF. And first of all, I'd like to thank the ILFA community for their amazing help with me through the years, especially the last couple of weeks. Maureen, thanks so much, and Nicola. But I also I like a big shout out to Gemma, who's done some Trojan work this last while with me, getting coverage of what I've done last week and over in Chicago, and making contacts with people with IPF charities in Chicago. It goes beyond words how much she works and helps, and I really like to appreciate her and thank her so much. I don't know who all's on this chat. I suppose a lot of you probably have heard about me or know about my story. I'll give you a brief rundown of it again and just let you know my latest accomplishment. As I said, I lost two brothers and a sister with IPF. It was devastating for my family. And then when I was diagnosed in 2015, it was really hard to take. But I was one of the lucky ones, I suppose. I got transplanted fairly quick, and I came out of the transplant really strong, and I'm so grateful. I've always promised that I would never stop trying to give back and create an awareness of the magical gift organisation gave to me and my family, especially my three children, small children, and my wife. So as I went on to raise awareness, and I did 3 marathons in New York, Berlin, and London, and they were brilliant. And I was so proud of them. I wanted to do 6 to get a Super 6. But of course, when COVID hit, that put a stop to everything. So COVID hit, and like everyone with IPF, it was a very scary time for lung transplanted patients for obvious reasons that we all know why. And I did all the protocols, did everything I could, but unfortunately, I picked up COVID and was sent to the mater and was getting the best treatment. But the COVID got hold of my lungs, and it just wouldn't let go. And I had to be put on life support and into a medically induced coma, which is probably one of the hardest things I've ever done. I had to say goodbye to my family, my 3 children, my mum, dad, and sister. And it's a hard thing to say goodbye to somebody that you might never see again. And no one should ever have to do it, or no one should ever have to hear something like that. But fortunately, I came out of the coma, and I was still around to fight again. Unfortunately, though, my kidneys failed. I had total kidney failure, and I was on dialysis for over 3 years in Cavan. So lo and behold, my wife, who's been with me for 31 years all through this journey, she sent her blood to get tested and found out that she was a perfect match for a kidney, and she donated her kidney to me last July, which was just to get one gift from a donor, an unknown donor with my lungs, but then to get a second gift from your best friend was probably the biggest reward I've ever got in my life. Like, apart from my 3 children, of course, but it just showed the bond that family have, when you've gone through struggles, how strong you can be together. So by getting that kidney transplant, it meant I could get off dialysis and I could start dreaming again. And my life was back on track. Of course, with a transplant, you still always have to look after it and protect it and all that kind of stuff. But I was able to dream. And my wife then, she wanted to do a marathon, so she suggested we do Chicago, the next marathon on the list. So I thought it was only fair that I would accompany her and try and have the 2 kidneys cross the line at the same time. So that was the plan. My lung function, unfortunately, had dropped from 94 after my 3rd marathon in 2018 down as far as 30. So I'd severe breathing problems and whatever, but I thought it was a good way of getting fit and working my lungs and trying to power them up again. So I did work. I started this year training, and just walking, just simple walks, a kilometre. That was all it was, just getting outside the door and to build it up. That was the goal, to build it up. But unfortunately, the training went bad. I fractured my fibia, my left fibia. I got COVID again in the summer. I got diagnosed with cancer cells that had to be removed. I was also doing antibody treatment as well, antibody treatment in my arm, which is very, very hard. So the training kind of went out the window, and I thought the marathon was gone. But I'm a very lucky person, and I have great friends around me. And my chemist and a dear friend, Dave McNally, kept at me to not give up. So he kept at me, got me back out again, and I started training harder again the last 2.5, 3 months. And I got into the pool. I know it's not suggested with transfer patients to go swimming, but I was being very careful, and I was swimming on my back to improve my breathing technique. So I did, and I went over with my wife, and we completed the marathon on the 12th last Sunday week over in Chicago, which was probably, apart from the coma, it was the next hardest thing I've ever done, because it wasn't your typical time of a marathon. I had to bring a POC, a portable concentrator, with me for oxygen, because my oxygen levels would drop when I start moving down to 85. So the only way to get around this was to bring the concentrator. And my friend Dave McNally, he carried it with him around the whole course with 4 batteries. It weighed over 2.5 stone, and I don't know how he did it. It was just a miraculous accomplishment what he did. He also got bad news when we were doing a marathon, that his uncle had passed away, but he never said anything to me. And we kept going. I started off wrong. I was supposed to walk and build up the capacity in the lungs, get them moving, and slowly speed it up. But with the atmosphere in Chicago, I took off running. I thought I was a young person again, and I took off running, and the lungs backfired straight away. So the first 200 meters was very bad, and it just got worse after that the whole way through. But I started thinking about all the people who never give up on me. The amazing staff, the nurses, the consultants, everybody in Cavan, the dialysis people, my family, my friends, my community, ILFA, all the community around ILFA, that never give up on me. So I wasn't going to stop. I wasn't going to give up. I wasn't going to pack it in. So I just kept walking. I kept going. I got the head down. I'd have to stop and take a breath to let my lungs recover a bit. So, but I wouldn't stop. And the further I kept going, the more I wouldn't stop. And my wife was there, Dave McNally, and 2 other friends. So we had 5 of us as a team. At that stage, they were clearing off the track, the roads. We were kind of on our own a lot of the way. But I wasn't alone, because I still had my donor on my shoulder that gave me the amazing gift. I also had my siblings that was in my corner, and I had my parents and everybody. So I have always said there was probably an 80% chance that I wouldn't finish it, but there was a 20% chance that I would. I only need 1% chance to do anything. I've survived the coma with 1% chance. So if you think about it, the odds were stacked in my favour. So I just kept going. It took me 10 hours and 39 minutes to do the marathon. It was grueling, to say it would be an understatement. Everything was sore, the legs were sore, the knee was sore. My lungs were very sore, but I was protecting them. I was stopping. I wasn't overextending them. And I did finish the line, and it's probably one of the proudest medals I've ever got to have. The Chicago Marathon, the medal. I know medals mean a lot, but this means so much to me. I actually got 3 spare ones for my kids to frame them. So if anything goes wrong in their life, they'll know that anything's possible. And that's what I'm here today talking to you about. Patients and whoever, when they're diagnosed or going through a bad time, to know that there's always somebody in your corner. There's always, especially with ILFA, that they're such a great community and advice. They give great advice and support to patients. They give it to me, and I'm an ambassador with them, and I will never stop giving it back to patients. Just simple advice on how to control symptoms and difficult situations. So it was just an amazing accomplishment for myself and wife to finish after what we've gone through, for giving me the kidney and the comas and everything to finish a marathon together. So I'd just like to thank everybody for all the wonderful messages that they give me, and just remind them that there's always hope. You never stop fighting until the whistle goes. I'd be lucky to be involved in sport, and I will never stop until that last breath is gone. And I've realised how to live life in a more positive way, in more outgoing, and not get caught up in the clouds and the dreary stuff, and to try and live life in a more positive way. So once again, thank you all so much, and thanks for listening to me. I won't hold you up too much because I'm sure it's lunchtime, but if there's any questions, I'd be happy to answer them. Thank you.
David, first off, can you hear me?
I can, Maureen.
Oh,
Yeah.
okay. The IT crowd solution, turning it off and on again worked for that. So thank you
Good.
so much for your inspiring story. There is always hope. I think that's a brilliant point to leave it on. And like, what an incredible feat that was for you to accomplish. I've never run a marathon. You've got the marathon done. Brilliant.
Yeah.
And as you say, it was a support structure around you. I think
it was. Yeah. I had one thing that I think there was 47,000 people running it. I had one thing that was stronger than any of them. It was my mental resilience, my strength, my support group, and they didn't. I had an advantage when you look at it. They might have been fitter physically, but I was fitter mentally. And to do a marathon, you have to be mentally fit, and I had that in my corner.
Yeah. Oh, that is absolutely fabulous. Thank you so much. You've really inspired us, David. I really appreciate it.
Thank you. You're very welcome.
Thanks. Quick question. Do we have Adam? Are you still with us, Adam?
Oh, here.
You are. Oh, wonderful. Thank you. Listen, we did have a few questions that came in,
Sure.
and I wasn't able to give them to you because of the technical problems, but those are sorted now. So if folks want to stay on and hear the questions, we've got a few of those. Paula, I'm not sure if you're still on as well. If you are, feel free to bring on your camera and unmute yourself, and we'll kind of throw the questions at you if that's okay.
Sure.
Okay.
Yeah.
Wonderful. So one of the questions is, thanks very much for an interesting presentation. Adam, would you know if the new drug for pulmonary fibrosis is better than the existing antifibrotics?
So we've limited information, although it's a clinical trial. Until it's rolled out and we see like large scale use, it's very hard to really know that with any certainty. One thing that's, I guess, exciting is that it works in a different way to current antifibrotics. So there's a kind of an exciting possibility that they will be compatible. They could work on two different things at the same time, that you may be able to use them as a dual therapy. That would be really cool because then you're hitting it in two different ways. But I think one thing about the drugs is that the side effects were a lot less. So there was no gastro side effects and things like that. So they may be tolerated in a better way, which would mean they're probably going to end up working better because people can take them easier.
And as you said, it's been approved by the FDA in the United States, but it's probably going to be a little while before it comes to Europe.
Yeah,
And then
there's all sorts of, there's no clarity on that for the European Medicines Agency. Now have to look at it. They, the company have to file all sorts of marketing stuff and lots more information. So I don't have a view on how long it's going to take before it's available here.
okay. Well, fingers crossed.
Yeah. But it's exciting, I think. Yeah.
It is. There was an earlier question that came in. So this is for either of you, I suppose. But actually, before we do that, David, so there was a couple of comments for David, not questions, but comments. One was, well done, David. What an inspiration you are. Keep up all your hard work in driving awareness to support people with this condition. That was from Chris. And then amazing webinar. Well done to everybody, especially David. So there you go. The next question was is there a relationship between rheumatoid arthritis and pulmonary fibrosis? And if so, can you talk about that a little bit?
Yeah, so there are some conditions, rheumatoid type conditions that have pulmonary fibrosis as a component of the disease. So some patients can get fibrosis. So it's interesting. So for a long time, they treated kind of revolution in research in IPF kind of happened because clinicians used to treat with steroids, so essentially anti-inflammatories to IPF patients. And there was a large study that actually found that that was a bad idea, that some of the patients that got steroids wasn't helping their fibrosis. In fact, it may have been making them worse. So Yes, there is lung fibrosis in some rheumatoid associated diseases, but it's likely a different type of lung fibrosis, or at least responds differently to therapies. So it's really, really important that the doctors are able to diagnose the specific type of lung fibrosis that a patient has, so they can come up with an appropriate therapeutic regimen.
Okay. Paula, here's one that might be for you. Is there any site or specific advice on appropriate portable oxygen devices for IPF patients to enable travel away from existing oxygen tank systems? So for example, for international travel or car journeys.
Well, for car journeys, depending on your oxygen needs, if your oxygen needs are not too high, you can use the portable concentrators. It's just that they don't suit everyone, like the Enogen or the Sequel Eclipse. But again, you need to be assessed properly to make sure that they meet your oxygen needs. For travel, sometimes the best thing to do is actually organize oxygen over in the country that you're going to, so that you have a concentrator there, maybe a supply of oxygen cylinders there. And sometimes maybe for the flight, depending on the airline that you're flying with, you can organize oxygen with the airline that you're flying with also. But there is a lot of options. So like liquid oxygen, it may not suit for travel because it will evaporate. But usually I would talk to your respiratory team about that. And even the oxygen companies may be able to guide you on different systems that work for you. And you can go back and talk to the respiratory team about that, because we're always open to different options oxygen wise.
Okay, great. Thank you, Paula. We'll do one more question and then we'll wrap it up. But just before that, there was one about, how do you find out more about clinical trials? One thing that you can do is you can go to clinicaltrials.gov, and there's loads of information about clinical trials, including what country they're in. We also, on ILFA's website, there's a page on clinical trials that provides a lot of information about that. We can't promote one clinical trial over another, but what we can do is we can at least make information available to you. So if you go to our website and you look at the clinical trials section under information and resources, you can find some information there. The last question then is, and this one's kind of a biggie, Adam, is how do current drugs affect disease progression?
Yeah, so it depends on your disease course. So that's kind of very variable. So there's, different kind of three major ones: are slow decliners, people who might have a faster decline, or people with stepwise decline. But the issue is that the current therapies slow the decline, but they don't restore it back to the original lung function. So if you're losing lung function, it can stop that slope going down. It can, make it a little bit shallower, but it won't bring the therapy, the lung function back to where it started from. And that's a big issue, obviously. So that's where we're trying to understand, how can we restore that lung function back to where it started from.
Okay. Thanks for that, Adam. And again, just on the clinical trials bit, one bit I forgot, but it is on the website if you do go there, is talk to your specialist. So if you're not at a specialist center, make sure that you get referred to a specialist center, and then at the specialist center, talk to your team there about clinical trials, and they can give you more information as well. Well, with that, I think we're going to go ahead and wrap up. The only other thing that I will say is we've got Christmas cards on offer here with ILFA. If you want to get Christmas cards, contact info@ilfa.ie. And then just a last big thank you, since this is our last webinar of the year, to our speakers today, to Adam, to Paula, to David, to Aoife and Anja, but also to all of the speakers that we've had this year that have given us such great information and helped our patients out so much. Truly grateful to you, to our volunteers, to our fundraisers, to our advocates, to everyone who's been involved this year. Thank you so much. Looking forward to a great 2026. If you'd like to volunteer with ILFA, we're always looking for volunteers. Once again, contact info@ilfa.ie, and anything else we can do for you, just let us know. Thank you so much. Have a great day.